So third degree AV block, I like to think of this as a divorce. The atria or the SA node and the ventricles, they were married and they worked together, but now the AV node has come in between them and they have gotten divorced and they're having to function on their own. Okay? So we know that normally electrical conduction starts at SA node, goes down through the atria, and then continues on through the AV node and into the ventricles, right? Well, with a third degree AV block, the SA node is going to pace, and it's going to pace the atria, so you're going to have a P wave. But because that conduction is fully blocked at the AV node, the ventricles are going to say, hey, there's nothing happening. So I guess I need to be pacing. And so essentially what's happening is the SA node is pacing and the ventricles are pacing. So there's not going to be any correlation between what you see the atria doing and what you see the ventricles doing. Your third degree AV block is the most serious type of heart block. Especially if the ventricular pacing is lower, your rate's going to be lower, all right? Most of the time, you're going to see a wider complex, okay? There's not going to be any association between your P wave and your QRS, meaning there's not going to be any association with your PRI, right? So the atria and the ventricles are completely blocked and separated from each other. They beat independently of each other. The SA node's going to fire at 60 to 100 because the SA node is firing at its own pacing rate. If the ventricles are paced lower, you're going to see a wider complex at a rate of 20 to 40. If it is pacing that starts in the junctional tissue just below the AV node, you may see a little bit higher pace and you might see a little bit narrower of a complex. Okay? But for the most part, you're going to see P waves and wide complexes. Your ventricular rate is going to be lower than your atrial rate. There's not going to be a correlation between your PRIs. There's no PRI. If you see a PRI, but it's a third degree AV block, then it's just coincidence that it fell that way. And I'll show you what I mean here in just a minute. Termed AV disassociation because the atria and the ventricles, they beat independently. Some P waves can be buried in the QRS complex and not visible on the EKG strip. If I'm counting an atrial rate, though, I still have to count the P waves that are not visible. How am I going to know that?
Are the P waves regular?
They are regular. The P waves are regular. So I'll be able to check my regularity of my P waves and figure out where another P wave should fall. And then if I go and check the next and then the next, then I would know a P wave is there, it's just hidden. So your rate, atrial rate is usually 60 to 100. Ventricular rate is based on where the escape pacemaker is. Is it higher in the junctional tissue? Then it's going to be a little bit higher of a rate. Is it lower in the Purkinje network? It's going to be a little bit lower of a rate, or a lot of it lower of a rate. Is there a P before each QRS? There's no relationship. They hate each other. They're divorced. They're doing their own thing. The only time they see each other is when they go to court to fight over custody of the Beanie Babies. What is the length of the PRI? None. There's no PRI. No PRI. Do all the QRS complexes look alike? Yes. Do all the P waves look alike? Yes. Is there any correlation between the P waves and the QRSs? No. So let's look at a couple. So, if you notice here, I marked where the P's are. but my atrial rate is actually 80, even though I have 60, even though I only have 6 P waves showing up. Why is that?
Because there's going to be one in the QRS.
Yep. So if I, again, y'all got to go back to your basics. And if you're not measuring your regularity, you need to get back into the habit of doing that. So that's regular. So there should be a P wave right there. There, 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 and then there should be another P wave right there, but it's hidden.
So when we get asked about the P waves like on a quiz, would we just say that they're varying since some of them are hidden and some aren't?
Just say they're regular.
So that should be, what is the other one? So it's 1, 2, 3, 4, 5, and okay.
Now, also on this, you will want to identify that the atrial rate, you want an atrial rate, you want a ventricular rate, and you also want to say that the atrial rate is regular and the ventricular rate is regular, but there's no correlation between the two. Is it an irregular rhythm? It's an abnormal rhythm, that's for sure. But it's really hard to tell, or it's really hard to just say that it is, as a rhythm as a whole, that it is irregular, because the SA node is beating regularly and the ventricles are beating regularly. They're just doing their own thing.
So since the QRS complexes are regular, we can still measure those to get our QRS length, but not the P waves because there's
Yeah.
there's no correlation between the P wave and the QRS to get the QRI.
Yes.
Yeah, and if you're measuring this, I would measure from right there about right there. So that's really a narrow complex. Okay. So that's where your P waves are supposed to be at.
The big hallmark for this one is just the different rates.
Yeah, so the hallmark here is the SA node and the ventricular, or the SA node and below the AV node is pacing in its own thing. The ventricles are doing their own thing, and the atrium is doing its own thing. Now this one is going to be a wider complex, and this is going to be measured about right there, so that's greater than 0.12. So this is probably a lower pacing. But if you notice here, if I were looking at PRIs, well, first off, I notice that I've got P waves, but then I go to that PRI and there's no way. That's not a PRI. So in this case right here, what is their palpable pulse?
Would the QRS be the palpable?
So
20. They got a pulse of 20. I might even venture to say that this was taken, it's all computer generated, but if you saw something like this, it might even be a PEA. See why this is more of the serious one here? Because when we're just looking at, oh, well, that's 3rd degree, but when you really think in terms of perfusion, they ain't getting up.
So looking at that particular rhythm strip, what would tip you off?
What?
Never mind.
So with the atrial rate,
Is it me? Because that's like the first time somebody's done that today. Am I just intimidating? Very.
So would the atrial rate be 70 in this case?
1, 2, 3, 4, 4, 5,
1, 2, 3, 4,
5.
6, 70.
And the ventricle would be
20. Now, if this was moved over just a little bit and I had at least the contraction part there, then I could say it's 30, but it's not.
These are some estimates.
All right. Notice here on this one's a little tricky. If you were to say, well, I see changing PRIs, well, the difference here is that the PRIs in a second degree type 1 don't start long and get shorter. And if you were measuring atrial regularity, I would see that I've got some P waves that are covered up as well. So this is actually an atrial tachy rate, but it's also a little bit more of a narrow complex too, because I'm measuring from there to there.
So what would tip you off that that's a third degree blunt, like right off?
There's no correlation in the PRIs, and the atrial rate's regular, and the ventricular rate is regular, but I've got a atrial rate of 100, I think I said 10, and a ventricular rate of 1, 2, 3, 4, 5, 60. Because you remember on the type 2, the second degree type 2 that we looked at that was similar to this, we had a constant PRI, and then we had a P wave right there that had no complex, but it looked the same all the way down. Now, I admit this one is a little bit more confusing. Oh well. I don't know if y'all have noticed this, but I use a lot of the same rhythms that are in your workbook on your quizzes and stuff.
The ones in the back of the chapter, or the ones in the back of the book?
I'm so numb right now, I have not noticed.
Why are you dumb? It's just paramedics.
We'll get through it.
Acting so emotional over something.
I just be overthinking.
Quit overthinking.
None of y'all should be.
I need to be medicated.
All right. So, let's think back. Our first degree AV block. What's the hallmark sign of first degree AV block? There's two things that I'm really stressed about first degree AV block. It's a delay.
And there's an underlying rhythm.
You got an underlying rhythm, and your PRI is greater than what?
0.20.
0.20. That's it. Second degree type 1, also known as
Walking by.
Mobitz 1 or
Winkenbach.
Winkenbach. So,
It has widening.
what?
It has widening.
So it's got a progressively widening PRI, right? Not the P wave, but the PRI. And then you drop a beat. All right? So remember I said longer drop, then you got a Winkenbach. Okay? So what was the hallmark about the PRI in type 2, second degree type 2? PRI is constant.
Ventricles,
But it just drops the QRS.
And you have drop QRSs. And the severity of that depends on
Ratio.
the ratio, exactly. All right? And then third degree was the divorce, right? So the SA node's doing its own thing. and the ventricles are doing their own thing, right?
But they're not doing it at the same time, or matching up.
If they are, they just happen to be in the same place at the same time, but they don't talk to each other.
He's weird.
Yeah. Yeah. So,
That's just when they run into each other at the restaurant with their boyfriends or girlfriends.
the ones that they cheated on them with. Alright, I'm going to tell y'all a little love story here.
Easy.
The heart or like?
I'm going to tell y'all a love story.
Easy, Chuck. Easy.
So, once upon a time, a P-Wave and a QRS, they were out at a local bar, and they met each other, and they loved each other. The P-Wave, it didn't want to be away from the QRS, and they were just going about life normal. So normal that in fact that they decided to get married.
Oh, that's what it is.
So they were normal Sinus all day long. P-Wave loved the QRS, QRS loved the P-Wave. Wherever you saw the P-Wave, you saw the QRS. Wherever you saw the QRS, you saw the P-Wave. They were so happy that one day they decided to have a baby, and out came a PVC. Just kidding. But as time goes on, like a lot of marriages, the love grows cold. But they were trying to salvage it. But the P-Wave, it decided that it didn't want to really hang around the QRS that much. So it started having its distance, but it still came home. Notice I said it, because I'm going to let y'all decide who it is. Is it the he or the she?
He said,
Male.
Mr. Simpson said he, and I almost lost.
The P-Wave decides that it wants to come home pretty regularly, but it just keeps its distance. So you got a first degree AV block.
He has nowhere to go.
The P-Wave and the QRS, they're still together. P-Wave still comes home, but they're cold. They don't like each other.
He just took a job on the road. Come on now.
So they decide that they're going to try to work it out, and they decide to have another baby, a PAC this time, but we all know that a kid's just going to strain a relationship. Isn't going to make it better.
Let's get you a bigger check.
Yeah. But, so, eventually, the P-Wave starts seeing something on the side. And they are spending time together, the P-Wave and the QRS. But they start getting a little bit further apart, and they just notice the the QRS, the P-Wave and the QRS, they start noticing that that they're just emotionally distant. Like, that's not the man I married 20 years ago. And so they just start spreading out, and they're getting farther and farther apart, no matter what. And then finally, he just don't come home one day. But he calls her up and he says, "Hey, baby, I want to come home." So she's like, "Okay, I'll come home." And then the same cycle of abuse just starts over again. It just keeps going and going and going, and he just drops off from the planet. And she's like, "Okay, I can't do this. You've got to just not come back." He's like, "Well, give me one more chance." And her being the loving person that she is, she allows the P-Wave, we're just going to say it, she allows the P-Wave to come back home. But he ain't changed his ways. He ain't changed his ways at all. And now he's going out more frequently. He goes out, he comes home. He goes out, he comes home. And they don't get closer, they don't get farther away, they're just there existing. So they're second degree type 2. But we all know where this is headed, right? To the divorce. Because she can't stand it no more. The QRS, she's like, "Hey, babe, you're not my babe no more. You go do you, I do me." And they get totally divorced.
So now she's dating the pool man.
I guess so.
Okay.
If that's who it is.
Hello.
And so now, just like with any divorce, the P-Wave, she's going on, or he's going on about his life the way he wants to. The QRS is going on about his life the way they want to. PVCs, PACs, the little babies,
They're lost in the shit.
they're growing up as products of divorce. It gets dark. But eventually, they're just totally away from each other. And they're functioning on their own. And like somebody said, if they see each other in the restaurant, they just turn the other way. A love grown cold. The end.
I thought it was.
I feel like you practice this.
Hmm?
I thought it was somebody we worked with for a moment.
At the fire department, probably so.
I feel like we've all worked with
It's one.
All right. So, clinical significance of heart block rhythms. First degree AV block, there ain't none. If you're treating a first degree heart block, it's because you're treating the underlying rhythm. It'd be a sinus Brady, most likely. So if you're treating it with the bradycardia algorithm. Okay? Second degree AV block, Mobitz type 1. Usually it's transient in nature, which means that it'll show up and then go away, show up, go away. If it demonstrates a rapid rate and frequently drop beats, then we start worrying about cardiac output. You need to be able to identify these. Even if in here I'm saying that a first degree type 1 Winkenbach is not as serious, it could still be because everybody is different, right? They may have read WebMD last night and realized that they do need to get sick today. That's what happens sometimes. Second degree type 2, we're worried about this one, especially if you have more frequent drop beats because it could progress to third degree. So what you're seeing is really a progression of sick tissue, sick cardiac tissue. Whatever the cause is, something is causing it to get worse at the AV node. Okay? Now, if you've got drop beats, your cardiac output is going to be seriously compromised. So when we saw that third degree AV block, now I know I'm talking about second degree, but when we saw that third degree AV block and we saw all those P waves and then only 2 complexes, well, sometimes you can have a second degree AV block where you've got P waves and only a couple of complexes, right? Remember what creates a pulse. What goes to the ventricle, right? Whenever the ventricles are stimulated, that's when you have a pulse, okay? Your third degree heart block is also known as the complete or the divorce. Signs and symptoms exhibited by the patient may be indicative of severe hypoperfusion. I have seen patients, rarely, but I have seen them asymptomatic with it. If QRS complexes are narrow and the patient's asymptomatic, meaning that they probably got a higher rate than that 20 or 40 from the ventricular, then most likely the AV junction is pacing. Now, do know that I'm saying the AV junction and not the AV node, right? The AV junction is going to be the group of electrical tissue just below is where it kind of connects with the ventricles, right? If symptomatic, drug therapy or pacing may be indicated. If the patient's exhibiting signs and symptoms and the QRS complexes are wide, transcutaneous pacing followed by the insertion of a transvenous pacemaker may be indicated. All right, so let's talk about treatment for just a minute. Your high-degree heart blocks are going to be treated with the bradycardia algorithm. Now, we know that when we give atropine in bradycardia, what is the goal of us giving atropine? What do we want to happen?
Faster heart rate.
We want the heart rate to speed up. How is it speeding it up?
Blocking the vagal nerve.
By blocking the vagal nerve, right? It is an anticholinergic. So it blocks the release of acetylcholine on the SA node from the vagal nerve, right? So where is the issue with the AV block? I just gave you the answer.
It's a door, it's just a door on the AV.
Yes, where is the physical issue though?
In the AV node.
In the AV node, right? In the AV node. The SA node's fine. So if I give atropine, there is some acetylcholine. When acetylcholine is released and it triggers the SA node, there is some that goes down to the AV node that kind of gives it a signal that, hey, the SA node is starting to speed up, you need to catch up. Okay? With that idea, maybe atropine might speed up the heart rate a little bit if we give that in a high-degree heart block. But your most definitive treatment for a high-degree heart block where they are hemodynamically unstable is going to be transcutaneous pacing. You got to just take over, right? So remember that. We treat high-degree heart blocks with the bradycardia algorithm, so atropine is part of that. But your most definitive treatment is going to be just moving on to transcutaneous pacing. Now, testing purposes. Don't get this confused with treating your sinus Brady's and all of that, okay? For testing purposes for your higher degree heart blocks, where they are symptomatic or hemodynamically unstable, meaning blood pressure is low, pink box of death stuff, right? Testing purposes is going to say go straight to transcutaneous pacing, okay? For your heart blocks. But if we're using the bradycardia algorithm for anything else, atropine first, okay? If they are hemodynamically stable, atropine first in your high degree heart blocks, okay? Follow me? Make sense?
Symptomatic, straight to pacing. If they're not symptomatic, that's when you do atropine and then pacing.
It's kind of like.
For your higher degree heart.
It is, and I didn't really want to say that to where it confused everybody, but it is kind of like that same idea.
What idea? What would you say?
He said it's similar to the tachycardia algorithm, where you got to make a decision whether you pace or give drugs, right? But I don't want y'all to confuse the bradycardia algorithm as a whole with that, just when we're treating high degree. Because really, you're dealing with a different animal here than you are just a sinus bradycardia. Okay? All right. So let's do some practice.
You have the same key. Are these the same strips that are on there?
100%.
Okay.
Are you missing one?
No,
Are you
there's
missing?
two of the same.
Dadgummit. Okay. Let's move on to it then.
Can I ask a clarification
Sure.
question, just so we have it all in like, or I have it all in one sentence? The reason that atropine normally does not work on third degree heart blocks is because it is only going to affect the actual atropine is only going to affect the
It-
vagal nerve, and since this is a bigger problem than that, that's why it's not.
Its main mechanism or its main target tissue is going to be blocking the vagal nerve at the SA node.
And since we're not doing much, the block's not affecting the SA node.
It
it's an AP.
probably won't have that much effect on it.
Okay.
But it can possibly. Okay? So I'm moving past that first one. We'll move to this one. What you got? So it's not just first degree. Sinus rhythm or first degree AV block. What you got here? Why?
Because QA, and then it drops off.
Yeah. So if I were doing this, my rate, stupid. My atrial rate, 1, 2, 3. No, that's not the one we were on, is it?
No.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So my atrial rate is 110. My ventricular rate, what did I just count? 70? All right. My P wave is regular. Or positive upright, positive rounded, whatever. All right, my rhythm, my atrial is regular, isn't it? But my ventricular is irregular. So if you just put irregular there, that's fine. All right, my QRS looks like it's about. about 0, about 0, 1, 2. All right, so my PRI, this is what I want you to put. I don't know how to spell progressive.
Yes.
Progressive, and widening. And then our interpretation would be second degree AB block type 1. There's no underlying rhythm for that. Sorry, y'all can't see that real well. Alright,
Question.
answer.
When we're doing these in our workbooks and also on strips, you do want us to find out if this is a second degree block type 1. Do you want us, do you need to include winky back or Mobitz 1 either or just as long as we know second
You
degree?
know the type, that's
Okay.
Don't the same ones printed out on here too? Yeah, 1 and 3 looks like the same.
Oh, ding, ding, ding. They are?
I know.
All the review strips we've done in the past are all from there too. Alright, what about this one? My rate, my atrial rate, 1, 2, 3, 4, 5, 6, 70. My ventricular rate, 1, 2, 3, 4, 5, 60. And that's just because I got one drop. My P wave, it is positive, rounded. My QRS complex, I'm measuring it at about, I know I'm going out of order, but it looks like it's about 0, 1, 2. Rhythm, it's regular, isn't it? Is it?
I feel like that's a trick question.
No, it's not. There's no trick question. It is regular. What about my PRI?
Greater than 0.20.
Yeah, you are correct on that.
Was it, did you hope that's progressively widening?
No, this isn't progressively widening.
It's going to be
My PRI is constant. It's about a 0.28 or so. So what is it? Nuh-uh.
Oh, sinus rhythm over first degree.
Sinus rhythm with first degree. You've only got 2 to work with on this one.
Sometimes I'll be writing it like what I think it is and then underline rhythm of whatever. Do I get points counted off for that?
No, but it sounds more
Efficient.
efficient. Yeah. So there's a couple things here, okay? You've only got 2 to work with here, but we've got a wide complex. We've got a regular atrial rate and a regular ventricular rate, we think. But we've got an atrial rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, about 100 or so. But we've got a ventricular rate of 20.
What?
Huh?
Yeah.
Why don't y'all just let me stand up here and talk in it?
Well, half the time I feel lost anyways.
So what is this?
19?
Third degree?
Oh, you're talking about the.
Yeah, the rate is about 100, 110. It is. It's a 3rd degree. 3rd degree is the only one where you're going to see that real wide complex.
What do you
I'm trying to measure out, do this properly, to measure out my,
On these, on the real wide,
Just 2 missing.
on the real wide PRIs, I mean the real wide QRSs, y'all can just put wide bizarre. Because what really matters in this is it greater than 0.12? Okay. What about this one? I'll give you a hint. That's a P wave, that's a P wave, that's a P wave, that's a P wave.
That's a second degree heart block, type 2 with 1-to-1 ratio.
Yeah, you just gotta give me type two.
I can't find it in all of this on the next page.
Catch me outside. Longer drop. You gotta wake him up. Also known as a
Second degree, 80 blood second.
second degree type 1. Okay? Questions, comments, concerns?